I'm thrilled to introduce today's guest, someone who is what I'm going to describe as one of the brightest in the industry. And I say that with all sincerity.
Do I need to pay you now for that?
Someone I was very intimidated, actually, when I first got to know you. Your speeches, your presentations, always top notch, very polished. Rarely laughed at my terrible jokes, but very much a straightforward, analytical guy, which I think is important for the role that you play. Then I got to know you a little bit more, personally, and wow, you got a great personality too. But the opportunity for someone like you to serve in a pivotal role at the Michigan Health and Hospital Association, affectionately known Michigan Hospital Association, MHA. It is my great pleasure to introduce to the studio for the first time, Jim Lee. Now, are you Senior Vice President now?
That is my title,
So Senior Vice President of Data Policy and Analytics.
That's correct.
Did I get it right?
That's absolutely
at
correct.
MHA.
And let me say, that is a very fancy title for data nerd. Okay?
Data nerd.
Yeah,
data
nerd
All right.
is basically
All right.
what I am.
Well, we're going to talk about data nerds and a little bit about what you do and why you do what you do. But I want our listeners to get a sense of who you are.
Sure.
And in this podcast, it's a national podcast, so there might be folks in Michigan, they know you, they work with you,
Sure.
but I want the listener in Washington to get to know you a little bit more. So give us a brief introduction of your background, where you come from, and then we'll get into the mechanics of what do you do.
Yeah. Believe it or not, when I was a kid growing up, I did not want to be a data nerd. That's
Really?
not what I was.
Really?
Looking
What'd you want
do.
to be?
A baseball player, actually.
Really?
Yeah. So
Wow.
I played baseball in high school.
Nice.
Not very well. That's why I have a real job. My claim to fame is I played a brief period of time with John Schmaltz, who played for the Atlanta Braves, Hall of Fame
Now,
pitcher.
how did you end up playing with this guy?
He went to the same high school.
Get
that I did.
out of
Yeah.
here. Wow.
Yeah.
Class A high school we established already.
Yes.
So not a small school.
So he was an amazing player.
Yeah.
Obviously a future Hall of Famer, and I was not. So
you were not. So,
thus
but at least you got to know, right?
Yeah,
a little
absolutely.
bit.
Yeah.
Now, where was home for you? What was your home state?
Michigan.
Michigan.
I grew up most of my life.
Oh,
in
I did not
Michigan,
know that.
Yeah,
Okay,
most of my life
which
in
side of the state of Michigan?
Really, Lansing area.
Lansing.
Yeah,
Very
Lansing
good.
area most of my life. Yeah.
Very good.
And
So,
Michigan State grad. Studied political science and economics at
is that right?
MSU. Was wanted to work on Wall Street. Be an investment banker. And then I interned for the Institute for Public Policy and Social Research at MSU, which did social science research, and got really interested in data. And after I graduated, I continued to work for them. Moved on to another organization called Star Commonwealth. I don't know if you've heard of them,
absolutely.
out of Albion.
Albion.
And did program evaluation and research for them as well.
And that was that's a behavioral, correct?
Yeah, they do
facility?
behavioral health services. They
Yeah.
have a euphemistically called the boys' home.
The boys' home. Yeah.
Yeah.
Absolutely. So here you are. You're going through college. Realize, all right, I want to get into this industry. Then you transition and go over to. By the way, poly-econ was my major.
Oh, really?
So yeah, absolutely. Politics, science, political science.
I knew there was
economics. See,
something
we had a
about you
connection,
that.
right?
Yeah, absolutely.
Exactly. So we're both nerds at heart. But then you look at, all right, you go to Commonwealth, and then you're like, all right, I like it.
Mm-hmm.
Did you like healthcare? Did you like that aspect? What did you like about it?
It wasn't really about healthcare at Star Commonwealth that I was really interested in. It was really about, the really important work that they were doing and how they were helping families.
Yeah.
And then trying to better understand what made some programs effective and what were some of the challenges that we need to solve.
Yeah.
And how data can help with those challenges. And so that's the reason why I stuck with them for about 5 years. But then I pivoted. There was an individual there who worked in the information technology field, and he asked me to actually come work for him. And so I pivoted to the information technology space, and that's
was
how
it
I got.
private equity or
No.
So just in a public firm,
yeah.
whatever, working.
Yep.
Okay.
And that's how I sort of got introduced to MHA. They were looking for somebody in the IT field, and I started actually as their CIO at MHA.
Oh, I did not realize that.
And
What year was that, Jim?
That was a long time ago. That was over 25 years ago, probably. Yeah.
And that was, CIO was a relatively new title.
Yes,
So
absolutely.
So you're director, basically,
Yeah.
Chief Information Officer,
Yep,
right?
exactly, and really focus on the IT side.
All on the IT.
IT side, and then opportunity came to work on the data services side of the MHA. So my role within the MHA really is sort of bifurcated. I have two hats. One is we have a division that is responsible for collecting healthcare data. For example, our Michigan inpatient outpatient data. And that's data that's basically similar to claims level data that we collect. And we collect that data for every hospital in the state of Michigan. It's a voluntary data collection process that each of our hospitals provide to us. And we use that data to help us better understand what's going on in our hospitals, the utilization patterns, patient safety and quality measures and things of that nature. The state of Michigan uses that data for some of the public health processes that they have. So that's one area that, sort of that I'm responsible for.
Right.
The other side is what you're more familiar with from a policy and advocacy side. How do we use data to support our policy and advocacy needs? Take, for example, our battle with nurse-patient ratios.
Yeah.
And, the question became, what's the need within our healthcare institutions? What's the workforce need? What's challenges and struggles we had? And so we put out a survey and started collecting data on workforce issues. How many nurses are we currently looking for? How many nurses have we hired? What's the turnover rate? So one of the narratives from the other side was that, Michigan had a high turnover rate and nurses were leaving in droves or were going to leave in droves. We were able to use our data to really push back on that narrative and say, no, in reality, our turnover ratio for nurses is actually less than the national average.
Yeah.
So it's how do we use data to support the policy and advocacy initiatives that we have within the MHA. So that's the two sort of bifurcated nature of my jobs.
And very fascinating. So let's go back, 2 decades, almost 3 decades ago. Data collection was much different.
Absolutely. A lot of paper.
Yeah, a lot of paper, green bar or whatever it was. But really, talk to me a little bit about some of that transition into what we're doing now,
Sure.
In the data collection, because information is so prevalent. It's here. It's at our fingertips. Some can be skewed to meet certain needs. But take us through the journey of what you've worked through and where you're at today with it at MHA.
Yeah, so absolutely. When we first started data collection, even before my time at MHA, much of that was on paper or on what they call real tape. It was actually tape like a cassette cartridge, if some of your listeners are familiar with that.
Oh, yeah.
And we were getting that data. Then it transitioned to floppy disks.
Oh, yeah.
And then CDs.
Remember those? Oh, yeah.
And now we are doing everything electronically, right? And so there are no hospitals providing data, through any sort of
no one's sending
hardware.
You faxes or anything
No,
of that nature, right?
but we do know that faxing is still
It's
prevalent
still
in
prevalent. It
healthcare,
is,
right? It is a sort of means of information sharing, unfortunately.
But you have a portal now, right? And then that
it's all web-based
uploaded
application, and
the portal.
our members are uploading that data into our systems for us to ingest. Absolutely.
So, Jim, when let's just say that a hospital is listening today, maybe don't know all of the resources that MHA provides, and it's just an amazing amount of resources. But let's say a particular hospital has a union and they're working on data collection, right? Can they bring in the MHA? Can they come to you directly, or how does that work? And say, you know what, we want you to help us analyze X, Y, and Z. Is that a possibility? Are you doing any of that type of work?
We don't have a specific set of services that provides that sort of consultation work, but we are more than happy to do one-off.
So I'm just giving you an opportunity for more service, right?
Absolutely.
Yeah.
So at the end of the day, we provide member services to our hospitals.
Right.
If a hospital has a need and needs help with data analytic work, we are more than happy to help them with that type of work. It could be, we've had hospitals ask us around their community health needs assessment, for example. So my team isn't vast. I have 2 individuals on the analytics side, a little bit larger team within the data services, data collection side. But in the analytics side, there's only 2 of us. But, we're a mighty group, but we can do quite a bit.
Mighty group, absolutely are. From emergency rooms to boardrooms, systems healthcare rely on credible and continuous data. In this episode, Jim will provide valuable insight on how data is linked to patient care and policy. We'll talk about AI, advocacy, and of course, what does all this have to do with rural health? So, Jim, I want to talk in the studio, Jim Lee, again, your philosophy when it comes to the value of data, data. Can you share with us how healthcare leaders should view data and its role in their organizations?
Yeah, that's a great question. I think data at the end of the day is only valuable if it can help answer a question and ultimately solve a problem, right? If it can't do that, then really, why are we collecting that data?
Yeah.
And often we collect data sometimes just to collect data without really thinking through those issues. What question are we trying to answer and what problem are we trying to solve?
Mm-hmm.
And in healthcare, it's ultimately about, are we providing data to clinicians and nurses to help them provide better care to patients, right?
Mm-hmm.
Ultimately, the data can't help them provide better care, then what's the use of collecting that data?
Mm-hmm.
And I think for the most part, we've done a pretty good job of collecting that data to help improve patient care, improve patient safety and quality.
Absolutely.
I think where we've sort of fallen off or not done so well is we've created this burden on clinicians and nurses in front of their EMRs. I'm sure you hear that
every day.
from your team about, they're spending more time in front of the computers than they are in front of their patients.
It's true.
And I think that's the challenge that we have in healthcare, is that we have all this tremendous data that we need to collect to improve the care we provide. But how do we relieve some of the burden on clinicians, especially when they're sitting there spending most of their time documenting in front of the computer? In almost every industry, information technology really has been a force multiplier to help them improve efficiencies and be more productive, except for healthcare. I've seen a study where they believe that EMRs has actually been a net negative for productivity, maybe even 10%. That the advent of EMRs, or the requirement for providers to have EMRs, the burden really has driven productivity down by 10% versus increased productivity.
Right.
And I know we're going to talk about this a little bit later, but that's where I think AI has a potential to sort of flip that script.
Does. Yeah. One of the challenges during COVID, and we should have learned some lessons, and hopefully we did, the sheer amount of required data entry that Michigan, I'm sure it happened across the country, that Michigan required. I mean, census data and this data. And, I mean, at some point, what are we doing with the data? And I've often asked my infection control officer when, we're still collecting, information, and Randy, what are we doing with it? Well, I don't know. Well, what's the state doing with it?
Sure.
We don't know. When do you retire that? I mean, from your perspective, if a hospital executive is listening today, and should they have a work production model that says, if we haven't used this particular metric or this data set, let's scrap it? Because we spend a lot of our time in healthcare immersed in paperwork and data collection. When do we give it up?
Yeah, that's another great question. We fall in the trap of doing things because we've always done it, right? And that's an easy trap to fall into. And I would go back to what I said earlier, that, I think we need to always ask the question, is the data we're collecting helping to answer a question or solve a problem? And if it's not, then why are we collecting that data? And you have to be careful, you have to sort of be cautious about answering, well, what if questions?
Yeah. What if it to death?
And so you can really fall into that trap as well. So really focus on those immediate questions that you have that's going to help solve a problem, that you're facing within your healthcare system. And you're absolutely right. With the COVID data, it became sort of data that we were collecting just to collect that data.
Collect it.
And no one was really using it to, really improve the care that we're providing to many of these COVID patients or solve a policy conundrum.
So I have not. Have they retired a lot of those?
They have, Okay. Much of that is now voluntary.
Is it?
But again, many of our hospitals have already had systems in place, so it's easy for them to just send that information.
It is.
And so I see that information. Obviously, that COVID still exists. We still have cases of COVID within the state and across the U.S. and the world. There's other data that's being collected on top of that, including flu data as well, bed census, things of that nature. So some of that is helpful to better, understand what's going on from a public health standpoint. Yeah. But there are some data sets that definitely needed to be retired, and we have retired a few of those.
Yeah. Let's dive a little deeper into the weeds. All right, respective to MHA.
Sure.
So, if I'm a member hospital listening today, what is MHA collecting? Just give me a couple examples of the data you're collecting, how you're utilizing it and deploying that data, and give us maybe some some victory laps about data collection for MHA.
Sure, yeah. So as I mentioned, the primary data source that we collect is what we term our Michigan inpatient and outpatient database. And these are all the discharges that occur in our hospitals. And as I said, we've been collecting it for decades. I think over 5 decades now of data that we've been collecting. And it helps our hospitals understand sort of the utilization patterns and what's going on in our industry, in the state of Michigan specifically. We've also used that information to improve patient safety and quality. So we can use that information to look at readmission rates and better understand why certain patients may be readmitted versus others. Understand the challenges, issues with maternal morbidity, for example. We know that maternal morbidity and mortality continues to be a challenge, not only across the U.S., but here in Michigan as well.
In Michigan rural, yeah. So the data sets that come to you, the collection, voluntary on hospital side,
it is,
right?
Yeah.
And is the process easy? I'm not on that end of it, so I don't know.
Yeah.
And I guess when do you put a call out of action to get that data?
Sure. So the data is collected quarterly, so 4 times a year. We have a standard format that we ask our hospitals to provide that data in. It's like most other data collections. There's a standardized way we want that data so that we can normalize it and efficiently process that information. Is it easy? I guess it depends. The adage is if you've seen one hospital, you've seen one hospital, and that it's true for data collection as well. Some hospitals it's easier than others. We definitely don't take it for granted. There may be certain issues that pop up, especially when we've had hospitals who've changed their EMR system, and all of a sudden the entire data collection process, just goes haywire.
Yeah,
exactly. We've had hospitals unfortunately go through cyber incidents, ransomware, and those have been incredibly challenging for those hospitals to, honestly, data exchange initiatives are way down the list of their priorities when they're dealing with a cybersecurity issue. And so, our efforts to collect that data is important for us, but for them, we know they're prioritizing patient care and making sure their systems are up. So we've had a number of health systems, unfortunately, that have had cyber incidents, and that's been problematic in terms of our data collection.
That was going to be my question to you because, as we sat around the boardroom at MHA, some of our colleagues have been struck in the last few years of cyber attacks. And how do you, MHA, guarantee that information is protected? Because you're collecting demographics, you're collecting age, right?
Yeah,
those types
absolutely,
of things.
yeah.
How is that guaranteed protected?
Yeah. So we follow all the federal requirements governed by HIPAA, the Health Information Portability and Accountability Act, which provides very strict standards on how do you deal with this information, both from a privacy and security standpoint. But beyond that, we have Chief Information Security Officer Mike Nowak. I'm sure you've met him, and he and his team do an amazing job of making sure that our systems are secure. We also have outside vendors that help audit what we do and provide assessments to us to make sure that we are consistently always following through with policy and procedures. Because you're absolutely right. We are entrusted. We are trusted to make sure we collect that data safely and make sure that that data does not get shared with those that don't need that data.
So I want to transition a little bit and talk about something that's heavy on the minds of many administrators and you yourself, AI.
Sure.
So artificial intelligence. And there are some good applications of AI, and we're learning more and more as we go to conferences, as we hear speakers talk about this. We see politicians who either say we're going to divest this program or we're going to invest in it. A lot of conversation about it being used inappropriately or appropriately. Give me your thought process in terms of relationship that AI plays and what recommendations you would have for CEOs who maybe are curious how to deploy AI. Should they start slow? Is there something they can back into to see this? Because it can be very concerning, right?
Oh, yeah, absolutely.
I think anything could be used for good or evil.
So your question is a complex question.
Yeah.
How much time do you have?
Well, 3 hours.
3 hours?
You may not, but I do.
So, one of the things that's absolutely true about AI. It is rapidly improving and expanding in its capability faster than most of us can.
Faster
really
than we can almost keep up.
Yeah, absolutely.
Right?
Yeah. So as you know, almost 2 years ago, we had an AI task force comprised of members across the state, led by Dr. Joshua Koistra from Corwell, and we try to create a framework around AI to help our member hospitals. And at that time, Dr. Koistra, I remember this distinctly. I asked him, what do you think about AI? And he said AI to him is like a smart intern that sometimes lies a little bit. That's how he described what AI systems are now. But it's expanding so rapidly. I would say AI right now is really a very smart employee, maybe one of your smartest employees, that sometimes makes things up, that hallucinates as the term that they've used for AI. So AI has become, I think, a tool set that, if people aren't using that now, they should in their everyday lives, let alone in healthcare. But in healthcare specifically, I think you need to be careful and move slowly. I think you need to have a really solid governance process that helps guide your organization around how you're going to prioritize the investments in AI.
Yeah.
I'm sure you've been inundated with vendors who are saying
every day.
Just buy our product.
Buy
And I think every vendor now has AI in their portfolio, or at least they're claiming that AI is in their portfolio. And I think AI has a tremendous opportunity. We have a tremendous opportunity in healthcare by using AI. And particularly, and I've talked about this with others, around helping us remove the variation and friction that occurs in healthcare that really sort of slows things down, causes people to be, to be frustrated, increases costs within our healthcare system. Think about variation in care, for example. It's one of the leading drivers of patient safety and quality issues. The fact that we are providing, a patient that comes in has the same set of issues, but they have different outcomes because of variation. Or the friction that's in our healthcare system when someone's trying to make a schedule for an appointment or talk to somebody about the concerns that they have. AI has the capability to help sort of smooth some of that friction out to minimize some of the variation. But we have to be careful, because, again, there's a lot of promises out there, but very few solutions that have really shown to be of value, to provide sort of a return on investment, if you will. Ambient listening is one of those AI systems that have been shown to be of value. It's also shown to help reduce the burden that some of these clinicians feel of having to constantly document in front of, the EMR system, in front of the PC. So, picking those AI systems that are sort of resolving some of the low-hanging fruit issues, like ambient listening can do, I think is critical in terms of moving slowly before you run into everything that potentially AI could do.
So, Jim, based on your experience, nearly 3 decades of work in this industry, where would you caution hospital executives to stay away in implementing AI? In which area? Do you have one?
Yeah, well, the good news is healthcare, we tend to be very risk averse, right? For better or worse, depending on who you ask.
Right.
So right now, there are many AI systems that claim to provide better diagnosis than any human physician can. And depending on what research you look at, there's some evidence that's true, that these AI bots, systems, these generative AI programs can provide as good, if not better, diagnosis than a clinician. But we both know that, they can't. They can't be. Right. You have to have the human in the loop to help make those decisions. So I think we have to be cautious about promises where AI can replace humans in the healthcare system,
right.
At least for now.
Sure.
There is this notion that that AI systems will become super intelligent, if you will, and they will have the capability and capacity to replace humans. But we're definitely not there yet.
No.
And Personally,
It's
I'm not
awful
even sure
scary.
we want to
I
be
don't
there.
think we want to be there.
Yeah, I don't.
I guess we'll leave that open for debate in the next few centuries to come, right?
Exactly.
I don't think necessarily we're itching to find that out.
Sure.
But when you look at, let's transition a little bit. I mean, you're using all this data. There's value added to hospitals. The MHA is leading a lot of initiatives with that, and then we're interrupted. We're interrupted by something called, and it's what you and I studied, politics.
Yes.
The government.
Yeah.
The government's either overreach, requirement stipulations, withdrawal of certain funding. And we had a devastation delivered to us on July 4th.
Yeah.
What I would feel, and that was a signature on July 4th of the One Big Beautiful Bill. The impact to our respective, colleagues in hospitals in Michigan, millions and millions and millions of dollars. So as you look at this, and we know that we've had, this One Big Beautiful Bill, which is gutting essentially healthcare. From your perspective as a policy and analyst expert, how will this bill impact your specific field? Specifically to what you're doing with data collection and information sharing. And I guess what advice would you give healthcare leaders? How do we overcome this damage?
Sure.
Maybe you don't see the damage, but I'd submit that there's going to be some fallout from this bill, even in your field.
Yeah, absolutely. So one of the things we're doing immediately is trying to model the impact of these cuts on healthcare. So we know the very first shoe to drop is the elimination of the enhanced premium tax credits, or the EPTC.
Yep.
And anyone listening to the news knows that that's been part of the debate on the government shutdown.
Mm-hmm.
The Democrats wanted those premium tax credits reinstated, and the Republicans weren't ready to do that yet at this point in time. Unfortunately, that still has not been reinstated, and
Correct.
We're still facing in 2026 an end of those EPTCs. And so when I look at that from a data analyst standpoint, right now we have approximately 530,000 individuals just in Michigan alone who gets their insurance through the ACA marketplace, and 90% of those individuals have some form of subsidy or premium tax credits.
Mm-hmm.
So they are benefiting from the EPTC. So that's over 480,000 individuals who will be impacted by the elimination of the EPTC. National estimates, they're projecting that if those enhanced premium tax credits don't get reinstated, that 18 to 20% of individuals will drop out of the insurance marketplace.
Altogether. Yeah. Absolutely.
I think that's low. I think
it's
estimate's
very low number.
Because when you look at the data, when we first started the ACA marketplace, we had what they call advanced payment tax credits, which were substantial, and we had a certain amount of individuals, around 250,000 in Michigan, that were on that. But when EPTCs came, we doubled that number.
Yeah.
So twice as many individuals in the state of Michigan decided to get insurance on the marketplace. So I suspect that we will lose maybe upwards of 50% of individuals from the individual marketplace if those premium tax credits don't get reinstated.
Yeah.
And that has a trickle-down effect. Those individuals will then come to our hospitals as, no pay. And bad debt clients, individuals, and someone's going to have to eventually pick up that bill.
Right.
And those individuals, and they'll have, beyond that, there'll be long-lasting health repercussions, because many of those individuals will wait till the very last minute.
Not even seek health care.
Absolutely.
Due to the cost nature of it.
So that's some of the things that I'm worried about, that I'm paying attention to just kind of see what are the impacts immediately. So that's the first shoe that drops. The other, in the following year, then there's the work requirements for Medicaid. And we know that's going to have a chilling effect on those individuals who qualify for Medicaid, along with the redetermination process that's going to be required twice a year. Yeah. So all those things combined, we know is going to have a negative impact on healthcare, and especially hospitals. And it's going to be my team's job to really look at that data and really understand what does the data tell us, and what do we need to do to prepare for these changes.
Because you're going to need to collect the data so we can tell the story in Congress.
Absolutely.
And so what should hospitals be What can they do right now to try to combat this with data collection, and or do you give them some ideas about what should they be looking at as people come through the front door that could help tell their story? Do you have any suggestions about specific data that they could be looking at?
Yeah. So, for example, one of the other data sources that we collect is community benefit information from
true,
our hospitals. And so, we do that once a year. We provide a once a year data collection mechanism for that survey. But we also have a tool set that we provide free to our hospitals that allows them to track all those different programs, initiatives for individuals that don't have insurance or disease education programs you may have within your community. And I think that in itself provides a good story about all the services and those community benefits you're providing to your community that's required of hospitals that you do really to be good community stewards as well. So that data collection process, again, that tool set we provide for free. And, providing that information will allow us as the MHA to tell your story as well.
And community benefits at risk. I mean, if hospitals have no margin, they're not going to be contributing to food pantries or healthy initiatives, population health management. They're going to be in survival mode.
Sure. Yeah.
And that's the danger of what we face right now. But it's a reality of what we face, and we've got to use data. And we got to be able to empower talking points for whether it's clinicians, executives, to be able to have that elevator speech with their congressional leaders, state representatives, to tell them why this is all bad.
Yeah.
And MHA is there to help because you do a lot of work around gathering information. Now, you work primarily with, I know Laura will come to you and Adam and say, all right, we're getting ready to address this issue on the Hill. Give me the background of it. In light of that, Jim, tell me about, and I'm putting you on the spot, do you have one success story that you're like, you know what? I felt really good on that project. We gathered the data. We had measurable results. We impacted something. Do you have a story that really you're just really proud of the work that you did?
The most recent one is, as I mentioned, around our workforce survey when we were fighting that legislation that was intended to create mandates around nurse-patient ratios and things of that nature. So that data was very instructive. I think it helped us sort of tell a story on why we didn't need that legislation, why this would be damaging to our hospitals, how much effort and work our hospitals are already doing in their workforce environment, how badly we need nurses, and we're constantly looking for nurses. And so we were able to sort of use data to support the story, the narrative that we were trying to tell people. Because data, again, in itself is important. Does it help support a narrative? Does it help support a story? Does it help answer questions? That's one of the most immediate sort of
and
wins
hugely
that we
successful.
had.
Hugely successful, by the way. I know you were right there, behind the team at MHA, providing that data, and we told our story.
Sure.
And we were successful, today.
Yeah, absolutely.
We're going to face this again. You realize that.
Yeah.
And we're going to rely on you again to gather the data and to tell the story again. But it's very important, especially when some of the statistics you provided for us were like, what's our nurse shortages in this state? And giving us that data was just unbelievable, the number of nurses that it would require to meet the ratio, but where the vacancies are.
Yeah, absolutely.
And where are we going to get 5,000 more nurses? And all the challenges associated with it. Let's transition one last point before we break. This is all about rural health, this podcast is. Yeah. And my passion is rural health. I think it's important. Number one, we're the economic drivers in our community. Care is local. Folks that have transportation issues can't get to big cities, urban centers, tertiary centers, let alone they're backlogged, weeks getting people out of the ER. We take care of our community right here. We have great value, buy-in, quality is typically going to be high in those rural hospitals because we can change on a dime. We don't have to go through committees.
Absolutely.
There's great opportunities, but it is among the most challenging right now for rural hospitals. Since 2010, over 150 have closed in this country. Scott Becker was just on this podcast, and he talked about, 700 and some hospitals at risk of closing. Majority of those are rural hospitals. So my question to you is, how can, as we look at it through the lens of a rural executive, how can we use data to protect, defend, and advocate for rural healthcare. And I know you have a different perspective because you have to look at it. You talk about Corwell-led an AI initiative.
Sure.
Well, Hillsdale wasn't at the table, and that's okay because we that's not our bandwidth, right? But this is our, this is our bandwidth. We know that we have to save rural health.
Sure.
How do we use the data to do that?
Yeah, no, great question. And you identified one of those issues. We know that healthcare is a huge economic driver in the state of Michigan. And as you know, in many communities, healthcare is the largest, if not the largest, employer within that community. And I think there's a tremendous amount of data to support that, whether it's urban or rural hospitals. In Hillsdale, I'm sure you are probably the largest employer within the Hillsdale County.
One of the largest. Yeah.
And so, and that sort of message and using data to support that is another reminder to everyone that healthcare isn't just someplace you go because you're sick. Healthcare is an economic driver within your community, and without the hospital, what would happen to that community?
That's right.
How do you attract?
We've watched that, right?
Yeah, absolutely.
Communities like Albion, Michigan, where their hospital closes, economics are impacted. Community is devastated. Individuals do not want to relocate business and industry where there's no health care. Moms are not sending their kids to college, and dads.
Absolutely.
So there is that challenge, but utilizing it for that purpose.
Yeah. The other data point that comes to mind is, the challenges we have with maternal services, and I know you understand that.
Yeah.
We've had a number of small and rural hospitals who've closed their OB services.
They have.
And
many more to come.
Yeah,
sadly.
Absolutely. And one of the things that I think most people don't realize is, take for example, Medicaid as a payer. There's this perspective that Medicaid is just an urban issue, right? Versus, there's a large percentage of individuals in rural populations who rely on Medicaid. And when it comes to maternal health, there are more Medicaid births as a percentage in rural communities that are using Medicaid than in urban settings.
Sure.
So people sort of have this perspective or this bias that in Medicaid and Medicaid births are just an urban setting. But it's critically important in an urban environment as well. And these OB services that are closing, we're creating maternal deserts, right? OB deserts where patients have to drive tremendous distances to find OB services.
45 minutes, an hour and a half.
And again, if you're thinking about viability within these communities, if you don't have a hospital that provides OB services, then how are you going to attract young couples? And how are you going to attract employers and to really come into that community and set up shop? So healthcare has to be seen as, and hospitals have to be seen as a vital link, not just a cost driver within a community.
Agree. So if there are other, we have folks listening from throughout the country, if we have other states and executives listening, do all the state associations have data points, or is this just something?
A vast majority do have that. So many states have similar data collection processes as the MHA, but many of those are mandated by the state.
Okay.
There's only a handful that are voluntary, like the MHA.
Yeah. You're doing a great job, Jim. We are very grateful for the hard work that you're engaged in every day. You have been a tremendous resource to Hillsdale Hospital. We often quote, and our producer Kirsten can attest to this, we often quote a lot of the work that you're doing in the background as justifications for why we advocate for what we advocate for. And so I'm very, very grateful for the work that you and your team has done, continue to do. I mean, the fight is yet ahead of us.
Absolutely.
I remember one of your colleagues, Laura, said it best, it's maybe the end of the beginning, not the beginning of the end. And we know that, this one big, beautiful bill is at the beginning, but our hope is that we can end it. And there's going to be a way that we feel that we can achieve that. But certainly we just can't go out with, talking points that have no substance. We have to be able to support those. And that causes us to reach out to folks like you to have the data points that we need. So thank you for the work that you do. It's very, very appreciated.
I greatly appreciate that. And let me state that you've been one of the best healthcare champions that we've had.
Well, thank you.
And so I know at any point in time when we need somebody to passionately talk about these set of issues, JJ, you're always there.
Got to be, right?
So
we're trying to do this for every patient that walks through this door has a story. And we lose perspective of that sometimes as we want to look at it from the patient's lens. And it's hard to do that when you're fighting government and when you're fighting all these challenges. But really, what's easiest for the patient to have? And it's access in the backyard.
Yeah, no, you're absolutely right. We get sort of caught up in the numbers, but those numbers, there are people behind those numbers, right?
The faces behind them are really
it sometimes seems like just a big number when we say, 200,000 people impacted.
Yeah.
But they're your neighbors, right?
Yeah, put a name with that. Yeah. Put your uncle's name, your grandmother's name. So again, great to have you in the studio. And we do a closing segment. And what we want to do is inspire the next generation of leaders or the generation that are just rising up right now.
Sure.
And you're a veteran of healthcare. You're an executive. We call it a rural health recommendation. So every guest we have, we ask them to contribute a recommendation on rural life and healthcare. Obviously, you're in the metro area of Lansing, but it's still rural. If you were to go to Phoenix,
closer
Arizona.
to Grand Ledge.
Yeah, exactly. So if you could offer a tip for someone new who is working in healthcare, maybe it's some sage advice that you would give someone about how to make it in these very difficult times, we'd love to have your recommendation about what advice would you give someone today?
Yeah, I would lean into the opportunities that technology affords us. I think more so in rural settings, whether it's hospitals or communities, technology and like AI can be a force multiplier. It can help sort of level the playing field, right? A hospital like Hillsdale may not have the resources to recruit the very best employees at times. But with AI and technology, you can, again, level the playing field where you can have similar set of capabilities that is afforded to you through technology.
Sure.
And I think in rural communities that holds true as well.
Yeah.
Things that, just think about a podcast. It used to be that you had to have a very sophisticated studio to be able to put together a podcast to get information out to you, or you had to have access to a newspaper, a paper newspaper.
Yeah. Well, and look, we're doing this in the back end of my van. So, I mean, you can do it anywhere, right? Well, it is a studio, I guess, but still.
Now with with a cell phone and the internet, you can get information out there. And so, technology tends to flatten the landscape and give people opportunities that didn't exist before.
I'll agree with you. Jim, thanks for being with us today. It's been great to have you on the podcast.
Thank you. Again, appreciate the opportunity.
Absolutely. Thanks to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of healthcare every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so you never miss an episode. Until next time, remember the power of rural.